Hey everyone, welcome to Taking the Pulse, a healthcare and life sciences video podcast. I am Heather Hoops Matthews here in the studio today with Maynard Nexon healthcare attorney Matthew Roberts. Matthew, good to be with you.
Good to see you.
And I'm excited to welcome back today one of our previous guests, Dr. Kashyap Patel. Dr. Patel, thank you for joining us again.
Of course, I always look forward to this sort of opportunity of sharing what I'm learning. And of course, with the distinguished host like you as well as Matthew, it's always a pleasure.
Well, your kindness is just world-renowned in my world. You have had an impressive medical career with a lot of leadership roles. You founded and lead your own medical practice, Carolina Blood and Cancer Associates, and you are the past president of the South Carolina Oncology Society, as well as the past president of the Community Oncology Alliance, which is a national position, I should note. You just recently received a congressional recognition. If you would, tell us just a little bit about that recognition and maybe what you have learned from all your leadership roles.
Sure. Thank you for a wonderful introduction. So, U.S. Congress on December 14th entered my name in a permanent congressional record with a House resolution honoring my distinguished career. And they used specific language saying that I'm an outstanding citizen who set the gold standard for decades in a healthcare delivery. So that's the biggest honor for me as a first generation immigrant to come here. And I do feel that, there's been a lot of learning curve alongside climbing the tiers of leadership. When I started this kind of Blood and Cancer Associates, we were probably almost like 19th in the size in the state in 2003. And today we are the tallest and strongest practice standing alone by itself. Everybody else has been either part of an aggregation group. They've been sold over. But I can tell you that it's always a teamwork. I would like to be the front face of the practice, but my partners, my employees, beginning from the front desk girl, and everybody else who came into my life, including even people like you, Heather. I remember we met almost about 12 years back when I had my first book launch, and then we came across Matthew and his team through Polypisaric. So it's always like very, very kind of, I would say, spiritual experience for me to go through these all challenges, but also how we can solve it in a collaborative, cooperative, cohesive way.
Well, Dr. Patel, thanks again. It's always a pleasure to talk to you, and we always learn something every time we do. In your long, storied career as a physician and a healthcare thought leader, you have to interact with the federal government, the state government, and big pharma and private insurance plans. And sometimes there's give and take in those interactions as you negotiate agreements and special relationships that you have with those players. How have you been so effective in partnering with folks who you don't always agree on how certain things should be handled in the delivery of healthcare, because you found a way to reach a common ground with your healthcare partners who are not actually clinicians?
Right, and that's very important learning for me. So I used to get upset and irritated probably about 20 years back when I came across those different special interest groups. But what I realized was that if I kept my patient at the heart of every conversation. So I'm a businessman and I have to generate revenue to feed myself, to help my practice, to help my partners, to carry the payroll. At the same time, I also have a responsibility of being steward and custodian of those who don't have a voice. So whenever challenges arose, whether it's, a group had a specific interest to do one thing versus what our interests were, I always brought that Mahatma Gandhi's term that be the voice for the person who's voiceless, and you're only civilized if your weakest link in the society is not ignored. So I've always kept that at the center and forefront of my heart. And most of the time, I would say that I was able to create a compelling case. It's give and take here and there. And life is all about compromising. And if you don't compromise, if you're not willing to be able to come on table, we cannot make a progress for the betterment of humanity.
And that's certainly true. And in my conversations with you over the years, every one of them is about the patient. Even when we're talking about a transaction or a contract or whatever, it's interesting that you've been able to bring some of the government leadership and some of the leadership from pharma and the payer health plan community to your practice. You invite them in to see this is how we do things. This is how we run a patient-centric practice, and that's been effective to create some common ground with these folks.
Indeed. So, back in the first decade of 21st century, I invited Blue Cross Blue Shield leadership to come and talk to us. I actually invited Medicare director, her name was Elaine Jeter. I said, I would want you to come to my clinic. I would want you to help me understand the compliance piece, because I'm not somebody who's very much tuned to the laws and everything else. And they were so happy to see the transparency, integrity, and honesty. And from there onwards, in fact, I've been able to even work with the payers to design different delivery models. And I think, end of the day, the secret sauce of our success is, instead of looking at the payer, politicians, pharma, and other sectors as a kind of adversaries, we always looked at them as a part of the team, that we all have one theme, that is making patients' life better. And just to add one more thing, in 22 years, Matthew, our practice has not had a single lawsuit for the malpractice.
Wow.
Despite having 15,000 patients walking through the practice.
Right. That's quite an accomplishment.
That is an accomplishment. Yes. I remember, Dr. Patel, when you were here previously, which it feels like just yesterday, but it was 2021, you were rolling out a charitable initiative in the Rock Hill area, No One Left Behind, NOLA. If you would, give us an update on that effort and how it's going.
So it was one of those I call the last quarter, the last marathon, the last mile, and the last breath work. So in 2020, when I became the president of the Community Oncology Alliance, I saw the disparity as biggest challenge. So I spent close to 1,000 hours in 2020 learning about what led to disparities. And instead of waiting for the government to act, I thought, let me take the pulse into my own hands. So we designed a program called, initially was No One Left Behind, but my dear friend Holly Pisari said, Kashyap, call it NOLA, because it's going to be more easy to digest. And we started a not-for-profit, not really knowing what I was going to do. But within a matter of 1 year, we are able to address virtually every aspect of disparity for my clinic patient. Now it has become so popular that Florida State wants me to have them build up a statewide network. So I'm in touch with their State Association of Oncologists. There's a practice in California, which is hybrid mix of underserved minority in California want to do that. So from our practice, it's going to the national level. But the best compliment was we had a grant reviewer who came to see us from the state, because we had some funding from DHEC as a part of the NOLA. And she was in tears. She said, I've been to almost 1,000 plus inspections. I've not seen such a transparent, honest, and integral piece. And to cite an example, I've decided that every year I turn one more year, I'll be 62 years. I'll be putting $62,000 into foundation myself, because I believe that the cause is working and I want to sustain it.
Yeah, well, it's a great cause, and it is helping people, but is also being an example for governments and other institutions to recognize the issues of disparity and how they impact care, the provision of care and access to care in such a negative way. So kudos to you and your partners for continuing to further the efforts of NOLA. One area that's relatively new, as if you didn't have enough irons in the fire, that you're taking a leadership role in, which is very interesting, is this clinical study on the long-term impacts of the COVID virus and what they're calling long COVID. And I know you are speaking at an upcoming conference that I hope I'll be able to attend, and you're presenting on some of the clinical issues. This is something we have talked about, heard about in the media, but tell us a little bit about it, because this is something that I know you are putting a lot of attention and focus on.
Thank you, Matthew. We need a lot more visibility on this, because the acute phase of COVID is gone. The infection is pretty much under control now across the world. But what we are seeing is the remnants of the COVID RNA particle left behind in the body can trigger chronic inflammation. And the number of patients impacted or likely to be impacted could be between 8 to 15%. And that long COVID can do either the heart damage, it causes myocarditis, it can cause ongoing inflammation, brain fog, multiple tissue complications. And we've seen some unusual cancers in our clinic, which worries me. So what I decided was that I'm personally hosting this whole meeting from international faculty. In fact, the president of the International COVID Research is coming here to Charlotte to spend 2 days with me. And some of the physicians from Guy's Hospital London, as well as someone from France, are also joining virtually. I feel that the impact of the long COVID on society as a whole, beginning from excess healthcare costs. So to give you an example, one researcher from Harvard Economics says that we may need about $368 billion a year for dealing with long COVID for next 10 years. That means additional $3 to $4 trillion. That's just an economic impact. About 7 to 10 million Americans will be some or the other crippled because of the either brain fog or physical challenges. So we want to create a consensus, number one, call to action, what research is needed, and we'll be looking for funding for finding 10,000 patients, prospective data, to see if we find a triggering inflammatory marker. I can ask my pharma colleagues to develop drugs that are designed to deal with COVID-induced lung inflammation.
So let's talk about that. So if a person had COVID, do they have to have a specific variant in order to be subject to this risk of long COVID? Do they have to have certain symptoms? Because, a lot of people before the vaccine, they tested positive, but they had almost no symptoms. And then we know some people obviously got very sick and lost their lives. What types of patients would be affected by long COVID?
And that is a big question because the research has not covered a comprehensive kind of background. So what we want to do is make a very structured process where you go back and look at the detail about how many episodes of COVID they had, when did they get vaccine, do they still have antibodies or not, and then if they have comorbidities or not. I personally feel that patients with pre-existing condition like, diabetes, hypertension, cancer, or autoimmune disease, they are much more vulnerable, maybe 2 to 3 times likely. But it's a large number of patient population. So there are many unanswered questions we're trying to answer.
So do you have any recommendations for people that had COVID that maybe have separate comorbidities that make them more at risk? Where do they go to get answers, or do they have to wait till to hear more about the research that you're working on?
So we are trying to create a call to action where we'll reach out to eventually government agencies to start like COVID treatment, diagnostic treatment centers, because the number of patients likely to be impacted could be up to maybe 25 to 30 million patients in USA. So that's a huge number, and we have to look at as a country as a whole.
Yeah, for sure. Well, we know you're in the beginning of this, so we'll bring you back to talk about some of the what you learned, because this, COVID may not be the current threat from a public health standpoint, but I don't think we're done with its impacts just yet.
Right, exactly. I think we are seeing the long-term effect of COVID now. And then one of the researchers who's coming, I would say, if you come, I would love for you to have some one-to-one time with him. He's the president of the International COVID Research, and he's also a NASA scientist. He works on the virus physiology in the space. Has 200 publications in this space. It would be great for you to connect with him. So we can bring him on this podcast sometime down the road as well.
Great. That'd be great.
Well, I can't think of a better person to help lead this, Dr. Patel, than you, because you do put others before yourself. I see it in everything that you do, including in the books you've written. I have enjoyed books Between Life and Death and From Raindrops to an Ocean. Both of them share about your experiences as you've helped your patients face end of life with their diagnoses. You have any ideas for the next book? Is there a third cooking in your mind?
I have 2 open contracts right now with Penguin Random House, and I'm working on one of his the humanizing cancer. So our system has fragmented, compartmentalized, and taken reduced approach. So we've actually brought down human being to a disease, not a human being with emotions. So every one of us is an ecosystem. We have family, we have spouse, we have children, we have parents, but system kind of somehow ignores that. So one book I'm working on is humanizing cancer. How do we bring back the care for the patient where patient is empowered and not kind of fragmented? That's one. The second one is I have some about 8 to 10 some miraculous recoveries of the patients that even I can't explain. They were deemed to die and they're still alive in normal life. So what was different about those patients? Was it their hope? Was it their physiology? Was it their family? So I want to give a ray of hope as well that the cancer is not always about dying. Even when science says it, you're like 1 in 20 chance of living, you could still live 10 years, 20 years.
Right. Well, Dr. Patel, these are the kinds of issues that I wish that today's medical students could hear from you. Maybe you should do a lecture at some of the medical schools in the region to help them, because I think it would, the kinds of things you have dealt with and shared with the public could help with physicians, particularly as they are developing their skill set. So
They're the issues that really matter.
yes, they certainly matter the most to patients.
Yes, that's what I mean.
Right.
Yeah, I'm sorry. That's
Absolutely.
what I mean. Yes. So, Dr. Patel, it has been a blessing again to have you back on the Pulse. Thank you for your time. I look forward to all that you have going on, from your books to the study on long COVID, to the research that you're doing there, to really just your continued work at the Carolina Blood and Cancer Associates, where Matthew and I know you give each patient the time they need, and you determine, working with the patient, what that is. There is no time slot in your office. Thank you so much.
The last thing I want to bring up is, with certificate of need being refilled from the state, I think that will allow us to have services that many patients cannot afford because of out-of-pocket costs. Because, there are many services, for example, there is no center that does colonoscopy, many of the biopsies because of the high cost. So we may look into adding more services that really reduce the financial toxicity to the patients.
Great. That's great.
That's fantastic.
Yeah.
Well, to be continued then, my friend.
Okay. Thank you.
Safe travels to
Thank you.
Thank you.
Thank you very much. Bye-bye.
And for those of you who joined us today on Taking the Pulse, we hope you enjoyed this conversation. I know I always do with Dr. Patel, and we look forward to seeing you next time right here on Taking the Pulse, a healthcare and life sciences video podcast.